Greetings and welcome. I'm Heidi Mastrud, Director of Alumni Relations for the University of Minnesota School of Public Health. Thanks to all who are joining us live today, as well as to those of you who catch the recording afterwards. In a moment, I'll introduce our panel of experts, but before we begin, I'd like to share a few updates and housekeeping notes. Our school's experts bring clarity and scientific knowledge to a range of topics critical to understanding and managing the COVID-19 pandemic. We invite you to take a deeper dive into our collection of COVID-19 related science and research stories online. Health in All Matters is a weekly podcast produced by our school to bring more understanding of public health challenges across the globe and close to home. We include expert voices from our faculty and their colleagues around the world. Our premiere series focuses on COVID-19 and the many issues it brings into question, such as transmission and prevention, life in a pandemic, loneliness and mental health, and the medical supply chain. You can find the podcast on our website or subscribe on Apple Podcasts. On April 26th, Twin Cities Public Television premiered Our Invisible Guardians, a 30-minute documentary about public health and the many people who work behind the scenes on issues vital to keeping us healthy. Since the film was made a short 5 months ago, COVID-19 has changed our world dramatically, and public health is now far from invisible. You can still catch the documentary online and follow the conversation on social using #InvisibleGuardians. And we're holding many upcoming virtual opportunities related to COVID-19. A couple are listed here, but visit our COVID-19 website to view all events. I promise that in just a minute, we'll get to the conversation at hand, but in advance, I want to offer a few tips to begin. For those of us joining in real time, questions are welcome, and you may submit them at any time. Our audience Q&A will be at the end of our hour together. Please type your questions into the Q&A box, not the chat button, on your screen. That will help me track who's asked which questions. We'll get to as many questions as time allows. And we'll be recording this webinar and encourage you to rewatch it or to share it broadly after the event. So, we find ourselves in interesting times. Public health has never been so visible. Today's webinar is one that attempts to address just a few of the many questions that have been brought into the public eye since the novel coronavirus began to change how we work, learn, and live. Luckily, we have the vast expertise of our faculty, community partners, and colleagues across the nation to help us make sense of it all. Joining us today are 3 experts with unique experiences and perspectives related to COVID-19 modeling efforts. Our 2 panelists have worked with their teams to create and adapt high-profile models currently being used across the nation. School of Public Health Associate Professor Dr. Eva Enns is co-leading the 8-member interdisciplinary team that developed the model that helped inform Minnesota Governor Walz's stay-at-home orders. Dr. Abraham Flaxman is a faculty member at the University of Washington. He's a member of the Institute of Health Metrics and Evaluation, IHME, an independent global health research center at the University of Washington. Their team of global health metricians stepped in to help a local hospital anticipate patient surge from COVID-19. Their model's now been applied to provide accessible data for all 50 states and for dozens of countries. And our moderator today is Stefan Gildemeister of the Minnesota Department of Health. Mr. Gildemeister serves as state health economist and director of the Health Economics Program. Welcome to you all.
Thank you, Heidi. This is Stefan Gildemeister. I think I'm taking it from here. Yes, okay,
That's right.
Good. So thank you everyone for joining us. You may be asking, why does an economist lead a conversation about disease epidemiology and modeling? And I think it's a fair question. My answer is it's all hands on deck. We are living in unusual time. And we are perhaps even in the midst of a perfect storm, facing a novel virus that is moving fast and really appears dangerous. We are in a good place in Minnesota, but generally I think in a deprived public health infrastructure with insufficient resources and not a ton of good planning for a pandemic. We struggle, I think, with diminished social cohesion and trust in institutions, and we have a limited understanding of the pathogen and an understanding that is changing daily. So one of the tools that has been emerging to guide policy decisions, inform the public, and prepare operational responses to the pandemic has been disease modeling, and that is what we want to talk about today, namely disease modeling using different methodological approaches, the science, how effective we are in communicating about it, and what we are learning from the results. If we have time, maybe we can also think about what we've learned so far for the next disease outbreak that others are telling us we should be thinking about. So we're fortunate to have two outstanding speakers, practitioners and scientists to speak with today. Professor Eva Enns will kick this off with some background information, then Abby Flaxman will follow. I will then start the discussion with a few questions that I've thought about and sought input on, and then we'll open it up to all of you. I understand there are hundreds out there in the virtual space, so I'm looking forward to hearing what everyone has to say. So with that, Eva, take it away.
All right, thank you, Stefan. I will share my screen here. All right, so I'm just going to provide some background on the Minnesota COVID-19 model and the approach that we've taken. And I think part of the goal of this discussion is to kind of contrast two different approaches to modeling. So I'll describe what we did for modeling Minnesota, and this is a model kind of structure that has been used to model other locations as well. So what we did was develop a compartmental model, which is a way of using mathematical equations to represent the dynamics of the transmission of this novel coronavirus and ultimately the downstream COVID-19 outcomes like hospitalization and death. The model stratifies the population by age and the presence of underlying conditions. And so these are kind of reflective of our Minnesota demographics, and then certain things can depend on those features. And I will emphasize a lot that revision of the model is ongoing as we kind of more data becomes available and perhaps more US specific or Minnesota specific data becomes available. So this is really a moving and evolving process for us. So the Minnesota model follows the so-called susceptible, exposed, infected, recovered, or SEIR model structure that I know many of you have heard of now. And the idea is that individuals are initially susceptible to infection, they have no immunity, and then through exposure to someone who's infected, there's a potential for transmission. If they become infected, they enter an exposed phase, which is kind of that incubation period before there are symptoms. And then they progress to the infected stage, and then ultimately a recovered stage, which would confer immunity, we're assuming. An important feature of these models is how that susceptible to exposed transition occurs. So that's the process of infection. And so the rate at which that happens depends on a number of variables, including the number of contacts that are occurring in the population, the prevalence of infection among those contacts, and then the probability of transmission per contact, right? And so if you imagine a susceptible individual and their potential individuals that they might be coming into contact in the course of kind of their daily activities, right? The more people they contact, the more number of times they come into contact with that population, the more chances there are to encounter someone who has an infection, and they may or may not be symptomatic with that infection. And so the more opportunities there are for transmission. And so it's kind of this reinforcing structure that as more infections occur in the population, the rate at which susceptible individuals are exposed to infection increases. That's that exponential growth that you hear people talking about. These factors are also kind of the opportunities that we have to intervene to slow growth. So when we talk about social distancing or stay-at-home orders, we're talking about reducing the number of contacts that people have with each other. When we're talking about wearing masks or hand washing or staying 6 feet apart from people, that's part of reducing that probability of transmission per contact, where you might still see somebody, but the risk of transmission is lowered. So in addition to the kind of epidemiological states in this model, we also include hospitalization and ICU or ventilation use, because kind of the overwhelming of the healthcare system has been such a concern with this infection due to the fact that nearly the entire population is initially susceptible to it, and kind of the high rates of hospitalization and long durations of stay relative to other illnesses. And so from hospitalization or an ICU stay, some patients ultimately die, and so we have a death compartment, and others recover, and so then have that immune state. And in this latest iteration of the model, so we're kind of between iterations right now, but as we're progressing forward, we are including a kind of out-of-hospital death rate, since we are seeing so much of that here in Minnesota. So I'll just give a flavor of the kinds of outputs that we've seen from this model and some of the general insights that we've gained. So some of our initial modeling work was looking at different variations on stay-at-home orders and social distancing and the timing of those. So initially we had modeled the stay-at-home order, which was just that initial 2 weeks, you may remember, back in March, where we weren't sure how long that was going to last. And so that's our kind of original stay-at-home order scenario. Then we also modeled that same scenario, but included additional social distancing for vulnerable people, which we define in our model as those who are over 60 years and older. And so that would kind of, the idea was to continue protection for those higher risk individuals and hopefully reduce mortality and hospital demand. And then we also looked at what would happen if you extended the stay-at-home order in addition to having the extended vulnerable distancing in the population. So I think this exercise provided some insight for us into how these mechanisms were working within the transmission dynamics. So here I'm showing ICU demand over time, and the infection curves and other epidemiological outcomes kind of follow a similar trend, though the timing and peaks are going to be slightly different. The first aspect I would point out is that we do have this kind of little initial peak that occurs. So this is when our social distancing or stay-at-home orders are all in force. And so you can see that we have initial growth, social distancing went into play, and so then we have that decline. And so then the growth that occurs is when those stay-at-home orders expire, okay? So the red curve here is that original stay-at-home order. So you see very quickly, because at the point of when it expires, very few people have immunity, we essentially just have growth as we would have before. So we've delayed this potential peak, but we haven't really changed anything about the situation. If we extend social distancing specifically among the vulnerable population, what we noted is that we can bring down this peak a little bit. We don't really bring down the timing because those older age groups aren't the primary groups driving transmission. They don't have the most number of contacts. We do age stratify in our contact structure. And so it's really the younger age groups who have more contact and are driving the transmission dynamics. So we still see a lot of infections occurring. We still see a substantial healthcare demand, but those older age groups are contributing to fewer infections, and so aren't as likely to die. If we extend the stay-at-home order in addition to that vulnerable social distancing, what we really noted is there's a shift, right? So we don't really change the peak with extended stay-at-home, but we do shift it and delay it, okay? And so with these insights, it's really important to note that we're assuming that you don't reinitiate social distancing as you see these surges in demand, right? So that's an assumption. We're kind of saying, what if we did this once and then simulated there on out. We also aren't changing anything about the situation. And so the idea is, if you do nothing, if all you do is stay at home, then you delay, but you need to do something with that additional time. And I think that's been very clear in the governor's communications as to how he's thinking about these decisions as well, that we need to be making progress. And I'll talk a little bit about the kinds of things that might be. Another thing that we like to emphasize as modelers and scientists is the need to capture and communicate uncertainty. So I was showing single curves before that had a single peak and a peak of a certain level. But what I wanted to emphasize here is we have a lot of uncertainty about the dynamics, about what's going on in terms of population behavior, and even about the severity of the infection. And so here are a whole bunch of different curves that kind of represent other plausible values, that parameter values, and the resulting outcomes. And so you can see some curves are higher and peak earlier, other curves are lower and peak later, right? So there's substantial variability. And this is something that we continue to characterize and continue to update as data becomes available. But I think that's a really important piece to emphasize. So as I said, the broad insights that we've gained from this modeling is essentially that in the short term, social distancing limits infection spread and keeps healthcare demand low, but herd immunity remains low, meaning that there aren't many people who've had the infection. And so when we kind of stop social distancing, if we do so abruptly, then populations start largely susceptible again. And so we're kind of in the same situation we were in when we started. And so we'd see rapid spread. Right, but the key is we see that rapid spread if no actions are taken. So the key is to use that additional time gained by social distancing to do something with it. So capacity expansion, we've talked about expanding ICU beds, making sure that there's PPE available to healthcare workers, ramping up testing capacity and contact tracing staff and infrastructure. Also supports for sustained social distancing, understanding that maybe we can't go back to no social distancing. And so finding that balance between re-engaging with certain activities, but doing so in a way that maintains some of the social distancing that we were able to achieve. And then there's just the idea that the longer we wait, the more science we will have accrued about the pathogen, understanding both its epidemiological and clinical characteristics, as well as advances like treatments or better kind of clinical protocols for taking care of severe cases. So those are some of the important insights that we like to emphasize from our model. And of course, we have a number of limitations. You know, we're still early on in terms of the number of cases that we've seen in Minnesota and how those cases have kind of moved through the healthcare system. It's a long, severe illness lasts for a long time. So it takes a while to see everybody move through the hospital and ICU all the way to final endpoints. And then, you know, data in the US is incomplete. It comes from a variety of different places. It's not centralized in terms of hospitalizations and ICU needs. And then we're also kind of thinking about other aspects that aren't necessarily well captured in this model structure. So hotspots or nursing home outbreaks, and then thinking about how to do testing. And again, we're continuing to update and revise the model. And so this is an ongoing process. So with that, I will stop sharing and hand it over.
Thank you for sharing, Eva. And thanks for the background. Abby, are you ready to bring up your slides?
Yeah, let's see if I can pull this off. Can you hear me? And
yes.
See me. And now can you see my slides?
Yeah.
Indeed.
Great. Well, thank you so much, everyone, for having me. And thanks for putting together this panel. I think it's going to be really interesting to compare these different approaches. For those of you who have not seen what I have been involved in working on at the Institute for Health Metrics and Evaluation at the University of Washington, here's a screenshot of what you can see at covid19.healthdata.org. And what it shows is, in this part of the visualization tool, the number of deaths that we're projecting per day. I started in Washington State. So this is sort of the culmination of work that really began trying to provide estimates for the hospitals run by the University of Washington to help them with their surge planning, to help them really back when we were in the mid-March part of this scary curve going up, say, what should they expect coming in the coming weeks and coming months? And an example of this being used in a way that I'm really happy to see this being used comes from a tweet that I'll see if I can advance to on the next slide from the Washington State Governor Jay Inslee, who I hope, in part informed by estimates from this kind of model, was able, if you look at the date here, back almost a month ago on April 5th, to say that we have reached the point in our outbreak that we have more ventilators on hand than we need. And so we can return them so that states like New York and others who have not reached their peak can have access to them. This kind of state-to-state solidarity, I think, is a really great thing to see in an outbreak like this. And it's something that I think can be done informed by models. So the kinds of things that go into it are what I'm going to transition into talking about. And I'll try in particular to highlight some of the differences between the approach that I've been using and the approach that Professor Enns has described. Now, besides looking at deaths on that previous slide, we are also trying to project sort of resource utilization in the hospital system. I mentioned this really started in an effort to provide something useful for the University of Washington hospitals. And so you can see here on that same date, April 5th, what we were projecting might have been happening in New York. And I'll call out in particular how we don't know how many ventilators they have in New York, but we do project that back a month ago, they might have needed 5,000 plus ventilators per day. And if they have 718 ICU beds available, they probably don't have 5,000 ventilators available. This was a real, crushing surge that we hope New York is finally starting to make it past. If we look now onto May 1st, we are projecting that they are now on the downward trend of the spike of this outbreak. How do we do it? Well, our model really keys in on death data, and in particular on accumulative deaths over time. So this shows, for the most recently available data on Washington State, how groups have tallied 801 deaths directly due to the COVID disease. But of course, when we're making those projections that were used at the beginning of April, it wasn't based on that much curve. It wasn't even based on this much curve. We were looking at the curve up till the day we had it, and we were trying to curve fit, project out based on what we've seen so far, what things might look like going forwards. Now, we chose to do this because we believe that COVID death data is the most reliable source of data, most comparable across locations. And there's been a lot said recently about all of the shortcomings of death data. It's hard to get these deaths coded. It's hard to do it in a timely manner. There perhaps are excess deaths that are not being coded as COVID deaths. But with all of those pitfalls, I think it is still much more reliable than data on, say, confirmed cases, which is totally confounded by testing strategy, or data on, say, seroprevalence or infections, which we've heard a lot about recently, and has still some substantial challenges to getting in a representative manner. So how do we use this data? Well, first and foremost, we got to break it down to as fine a degree as we can. And you see here that data about deaths in Washington State now broken out into 3 different important groups in Washington State, and transformed so that instead of showing date on the x-axis, I'm showing time since a threshold where the log of the death rate crossed -15. And so that's transformed all of these different curves And in blue, you can see the Life Care Center, which is a skilled nursing facility near Seattle, where really our outbreak started. And I think it was a catastrophe, but it was in some ways rang an alarm bell loud and clear and helped us in Seattle and King County and in Washington State know that this was a major outbreak and had catastrophic risk. Shown in orange and green are King and Snohomish counties, which is where the outbreak first focused. It's where the Life Care facility was, and it's excluding the Life Care facility. That's outside of that particular skilled nursing facility. And then in green, the other counties in Washington State shown also below it, where you can see that these epidemics kicked off at different times and have had different trajectories. Now, the Life Care Center in Kirkland, I think of as a special case. This was a smaller population than the general population, and it was a population that was very exposed. This is an approach where I think an SCIR model, like Professor Enns described, would be really excellent in understanding the course of the outbreak in that facility. But I'm going to zoom in on the King and Snohomish counties and other counties in Washington, which has a much larger population and is a place where I think curve fitting can really help us understand what's happening. And the reason I think curve fitting can help us understand what's happening is because what I've laid over this now is the outbreak in Wuhan City in China. And what you can see is that these curves all have some similar features. They're not exactly the same, certainly not exactly the same, but they do all start to go up and then start to level out. And in Wuhan, where the outbreak started first and therefore has had the most time to advance, you can see it really has started to level off in this picture by day 56, meaning 56 days, since the death rate has crossed that threshold log death rate of -15. Now, this is the only slide that I've got with some math in it. So if you like math, here it is. And if you don't like math, I won't be on it for much longer. But what we have done is taken those cumulative death curves shown on the previous slide and posited what if they follow a curve with this parameterization, where d of t as a function of parameters alpha, beta, and p has this functional form. And if you like giving some meaning to these parameters, p will act as the maximum cumulative death rate, beta will control the location of the maximal curvature, which is a fancy way of saying where the daily deaths peak, and alpha will control the slope, which is to say how quickly the outbreak proceeds from where it starts to where it peaks. We now optimize to find the best parameters for the available data. And when I last gave this slide for the University of Washington, I wanted to call attention to how this is very University of Washington math to do this kind of optimization. I think the other thing to say is I'm surprised how hard it is to optimize this 3-parameter model. And sometimes we'll want to do it for multiple locations at the same time. So there's a lot of addition that we can layer on top of this. But at its heart, our approach is curve fitting, and it is finding the best values of p, beta, and alpha for the available data. And for those of you who don't like math, I think a really good way to make this concrete is to just think about how you do it. So this is from a version of this talk I gave before that I thought maybe I'd be scared to do a demo of, but I think I'm going to go for it. And so let's try to do a demo to say what parameter values might we use to make this blue line, which is our curve for this set of parameter values, look like the data from the state of Minnesota in the 24 days since it has crossed that threshold. So as I said, changing alpha changes how the slope looks as this goes up. Thank you for changing. And changing beta changes where it peaks, which in this view, you can't see the peak, but it's basically gonna move that whole curve to the left. And changing log p changes how high this cumulative curve goes. So you can see that -8 is way too high, But if I dial that down to -9 or -10, now this is like one of those cooking shows, right? Where I actually bake the cake beforehand, and I know that if I get a 0.07, 22, -10, the blue line is gonna, I hope, line up somewhat reasonably with those orange circles. Computer, if you please. You can still hear me, right? I'm not frozen. Okay. Down to 10. Well, anyway, you get the idea of what this is doing. And of course, we don't do it by hand for all of the locations. We use computers to optimize it. But I think that doing it by hand is a great way to see this isn't magic, and it's not something as complicated as all of those Greek letters might make it seem. It is curve fitting. So what we're doing with that now is trying to go from the curve fitting approach that we have focused on so far to something much more like Professor Enns was talking about, where we can say, what if? Curve fitting is good for saying, where are we headed? But those SEIR models and other more mechanistic models are much more important for saying what might happen. Now, there's a lot of interest in lifting social distancing. I would love to have my kids go back to school. It is hard, not doing all of the things I'm used to doing. But according to the approach that we've been developing, it would be catastrophic to go back to how things were before we started social distancing at this point. And so here is a kind of hybrid approach where we've taken the death model that we've been working on at IHME and then retrofitted it into an SEIR model so that we can say, if social distancing continues, here's a blue line for how we think we are making it past the peak and succeeding in crushing this curve. But if social distancing was lifted today, we would not be where we want to be. And most disturbingly, it might look like things were still going well for 2 or even 3 weeks, but we would see a resurgence through June and July, getting us back to this outbreak, back to this disaster zone. So I've got one more slide, which is to show you what we're projecting on our website right now for Minnesota. And I thought people in the audience might have a deep love of Minnesota and be interested in this. And we're projecting that the state of Minnesota is near your peak, 2 days until projected peak deaths. I think when I did this yesterday, so probably we're saying the peak is perhaps tomorrow. Now, there's a lot of uncertainty about that. So if you have time for just one number, we're projecting that 26 deaths will be the peak tomorrow on May 2nd. But I call your attention also to the lower and upper parts of this pink envelope, which is to say, we are not sure of that. And then I'll close by flipping to the web version of this. As I mentioned, you can go look at this now because there is some very important difference between what Professor Enns' results are producing and what our results are producing when it comes to resource utilization. And if I understood correctly from the previous slides, the SEIR model puts a peak of ICU beds needed in the thousands, which is very disturbing, and also about 10 times higher than where we're saying we think that things are going to peak in the hundreds, and certainly could overwhelm the capacity, where according to the data we've processed, we believe that the state of Minnesota has 355 ICU beds available now. So there's certainly some surge planning that still could be useful, but it is not the 10-fold scale up of capacity that's this other model has projected. Now, I think in our discussion, we'll be talking a lot about where these differences might come from, what you might do with this kind of information, and I deeply believe that you must hope for the best, but prepare for the worst. So I am not saying that this should be the only thing you look at in our model. On the other hand, if preparing for the worst means going from the hospital system you have to 10 times the hospital system you have, it's just very hard to make that kind of preparation. So I'll leave it there. Thank you again so much for having me. And I think it's been really great to convene this discussion.
Thank you, Abby, and again, thank you, Eva. Some good starting thoughts for a bunch of questions, and I should tell you, before you even started, there were a dozen questions already ready for you. So I'll maybe limit my questions to a number 2 or 3, and then open it up to others. I want to start with a question about how your work has changed. You've traded the comfort of academia for informing real-time, momentous decisions, and I think Abby sort of brought that to the point in his last comment, to sort of say, you know, what is the investment that states like Minnesota have to make? These are million-dollar decisions. We're talking about lives of hundreds of thousands of people. So how have you managed that transition from academia to informing policy and decision making? What surprised you? How has that changed your view about the impact of science in society? Eva, why don't you kick it off?
Sure. Obviously very busy, and kind of the kind of work that we would do over perhaps several months and several iterations has to be compressed into a much shorter timeline. And I think what has been really rewarding, though, is to, I mean, this is why we do this work, right? Is to ideally inform decision making. It doesn't always have to be real-time decision making in my mind. I'm happy with informing general insights into how we manage outbreaks and illnesses of this type, but being engaged in that decision making and trying to generate things that are useful, that provide useful insights to decision makers that aren't apparent just from looking at a bunch of numbers, right? Because that's really what these models are doing, is they're taking all of those numbers, they're taking kind of what we know, and maybe from lots of different places, maybe just from Minnesota in the kind of curve fitting case, but then trying to aggregate it into a way that a decision maker can gain insight into what the possible actions they could take and what impacts those would have. And so I think that's been really exciting, but it has also required us to kind of think about how best to communicate those results, and how best to communicate the uncertainty in those results. That's really been important for us, to not get fixated on a particular day of peak or a particular height of peak, but the general orders of magnitude and the general trends in terms of how different actions are going to influence. Do things go up or down? Are they delayed or not? And so that's kind of how we've been thinking about the modeling. And I'd say it's also been really nice to work with a set of decision makers who have been really thoughtful in using this information. They're not only using the model, they're not following the model blindly without other considerations, because the model obviously does not take into account all of the costs and other considerations and the real world feasibility factors that go into these kinds of decisions. So it's also been really nice to work with a decision maker who can use the model responsibly, and interpret it accurately. So it's been really nice too.
Thanks. Abby.
Well,
how has your life changed?
I'd say it's really been such a privilege to be able to help with this. And it's, for me personally, you know, I was a mathematician when I was in graduate school. I didn't know much about public health. I didn't know that there were places for academics to plug in and be helpful in society and in public health decision making and in governance. And it has been really personally rewarding to feel like you know, the math and stats that I've been learning, that I've been interested in, can be useful in this way. I echo a lot of what Professor Enns said. You know, that there are a lot of challenges to doing this in the midst of, pandemic, once in a lifetime outbreak, let us hope. And I'd say, some of the key lessons are, well, let's see, in academia, oftentimes we value novelty, and oftentimes we are worried that something too simple will not be considered novel by our peers. But in this sort of evidence for decision making, we have to be right. And if being novel means we're more accurate, then by all means be novel. But if something tried and true is accurate, I don't care if it's been done before. And we've got to focus on things that are going to get the information we need and get it on the timeline that it's needed to make decisions. If it's simple, that's a good thing. There's a lot of virtue to an approach that uses addition and subtraction and multiplication and doesn't require division, because that's something that I think is going to be communicable. That's going to be something that people who have to make decisions can understand where this evidence came from when they're factoring it into their decisions.
Yeah, thank you. I'll pick up there and sort of observe that, there's been a real overabundance of COVID-19 models out there, some out of the box, some with an interface, some producing estimates of on overlapping jurisdictions. They represent different levels of sophistication. They're characterized by varying degrees of documentation. They're communicated differently by different media outlets depending on what results they produce. What do we need the public to know about these models? I mean, just the two of you represent a subset of all models out there, yet Abby, you are willing to tell us tomorrow is when we reach our peak. Eva, I think, would be more cautious there. To what extent are we doing the public a favor by competing for attention, by drowning them in models, and how do we answer the question about which is better? Which model is better? How do we judge between models that are so radically different in their predictions? Abby, why don't you start?
Well, I'll tell you what the biggest risk is. And so I don't know what's right. That's a great question. But what's wrong is to pick and choose based on your preconceived notions. And in my experience, oftentimes a model is requested to justify something that has already been decided. And that is not a good use of time, especially when we're in an outbreak and time is of the essence. If a model is really, if you'll excuse my saying, a cover your ass process for something that a policymaker already wants to do, and they want to be able to then point to the model if things go wrong and say, well, the scientists told us, that is not a useful thing for us to be spending time on. On the other hand, if there are different approaches to knowledge, different ways of knowledge generation that are going to give us substantially different projections, and I think actually, I didn't know coming into this, but the ICU utilization coming out of these two different approaches may be a perfect example of that, where you say, do we need to get 100 new ventilators or 1,000 new ventilators? That's the kind of thing that I think it's really valuable to have these different approaches. And then, well, who needs to understand how much about them? I think that we all are in a place where we want to know more. this has just taken over so many people's lives. And it could be that policymakers who are going to be trying to build capacity for a COVID surge need to know more. It could be that everyone wants to know more. And I've seen very sophisticated reporting in the New York Times and other mass media outlets, just based on their expectation, I believe, that their readers want to know what goes into these models and what is it that we're hearing about on the news when we hear someone talk about the model projects this or the model projects that. I think, one thing that you made me remember and feel bashful for when you said how I'm presenting our model results is all models have these caveats, and it's very important to call out those caveats every time we utter a sentence about our models. Mm-hmm. I totally missed when I was talking through this so far. The projections from the IHME model assume that there is strong social distancing in place. And so when I say, I think Minnesota peaks tomorrow, that is if you keep doing what you've been doing. And I think that going in, it was very much of an unproven hypothesis that this strong social distancing would succeed. We had seen it work in Wuhan, China, but we had not seen it work outside of this one location. Since then, in the last month, we have seen that strong social distancing can crush the curve. And we've seen these death counts go up and come down in states in Italy and in Spain. And we're even starting to see it in the United States. But my model is assuming strong social distancing continues and works. Mm-hmm. And that's a very important thing to say, because people who don't want to do that might still like the results coming out of my model and want to have their assumptions with my projections.
Yeah, thank you. That's a good clarification. And I think what social distancing means is also really important to understand. Eva, your reflections. So many models. How does the public deal with the models, the outcomes, the differences?
Yeah, I mean, I think what's challenging is that these models can be complicated. I mean, there's simple models and complicated models, so they vary, but and in the best of circumstances, there's a lot that goes into them, a lot of different data sources and assumptions. And so it can be sometimes difficult to understand why one model is saying one thing and another model is saying another thing. And case in point, even the comparison that's been made on the ICU demand in our two models, if you look at our teeny tiny peak that is dwarfed because we are going out to that release of social distancing, our teeny tiny peak is not 1,000, right? It's 100, a few hundred. So we're not necessarily on an order of magnitude different if under the same assumptions. And so it's really important to understand, especially when you have both the assumptions on the disease and data and inputs, and any kind of tailoring that might be done to a specific state or population, as well as the assumptions on what's going on, what kind of counterfactuals are you modeling? And we're really focused on the counterfactuals because, as Dr. Foxman said, that that's the kind of key use of these SCIR models, is that you can change things and see mechanistically, if I change that contact rate, right? If I engage in that contact reduction, what do I buy in terms of the downstream transmission dynamics and epidemiological outcomes? And so it really is through the counterfactual comparisons. And so you need to make sure you're comparing apples to apples. And that can be really hard in this kind of model environment.
Yeah. So I'm going to jump to some questions from the audience. We have 60 questions, and we probably will get to 3 or so. The first question is from Dr. Camille at the Department of Human Services, the Medicaid director. He asks, to what extent do models, yours and others, take into consideration race and ethnicity and sort of the effect of structural discrimination on the shape and the outcomes for different people? And maybe if we can do brief answers, then we can grab a few more questions. Of course, nothing is simple. Eva, go ahead, please.
So our model is age stratified, and we do have underlying conditions which can exacerbate outcomes. And so we do have that in the model, but it's at a very high level. It's very much population level. And so further stratification could be possible. It would just require more inputs. It would complicate the model, but it's something that I think is important to consider because there are very real differential impacts both in access to care, outcomes with care, as well as exposures, because we're seeing a lot of our healthcare workers and essential workers, right, who are working our grocery stores, who are making sure that we can still that we can all social distance and shelter in place, that there's a lot of people who are still having to go to work and put themselves at risk. So I think that's an important consideration for future iterations.
Thanks, Abby. Thoughts from the IHME modeling?
Yeah, it's a great question. And the answer, unfortunately, is we do not include race and ethnicity in our model at this point. What it would take to do that is understanding deaths by race and ethnicity. So it's actually data that's available. If you look on death certificates, there is a place to write down the race and the ethnicity of the deceased. If that data was coming out in a daily stream, the way data on all COVID deaths among all ages, races, ethnicities was coming out, then we could refine our model to use it. And what I've seen from other data sources is that it's important. This echoes what Professor Enns was saying. In the Seattle area, for example, I've seen from emergency room data that there were different peaks based on white and Black race. And this reflects, I believe, segregation in society, that the outbreak functions through social networks, that because of social segregation, there were outbreaks that peaked at different times in the Seattle area. Without the data, though, we can't dig in to make that more quantitative.
Yeah, thank you. A question from the audience asks, what can these, well, many models are sort of at the state level. What can these model approaches do for smaller population of smaller jurisdictions, for example, for tribal nations on reservations? And if we don't have the data now, what data do we need to do a good job at the county level, for large cities, etc.? Eva, you look like you're ready.
Yeah, so for the compartmental model thinking, I think when you have a closed population, and Dr. Foxman mentioned, modeling within a nursing home, certainly you could use it within a nursing home. So similarly on a reservation, you could use the same kind of transmission dynamics. You would need to understand how much contact people are having with each other, and to what extent the mitigation strategies are possible, any kind of distancing that might be feasible or desired to be undertaken by that community. But I think what's also important is that you need to understand what's the kind of introduction in, and out, but if you're focused on outcomes for that nation, then you'd want to know kind of how much contact is happening external, so off of the reservation, what's the prevalence in those communities, what's the kind of frequency of contact, the transmission per contact. So it's the exact same considerations, but now you need to consider kind of the external community, because you're trying to deal with such a small population that isn't necessarily primarily driving its own transmission, particularly if they're taking measures to self-isolate from each other within that population. So I think that's an important piece. And the same thing happens with a nursing home. If you have a nursing home that has been closed down, where you don't have visitors, it's the staff that are kind of interacting with both the external community and the nursing home population. So you need to understand what risks do those staff face. And of course, they can also be exposed at work. So it's not to say it only goes in one direction. But those external kind of within a population of interest and contexts external to that population become really important the smaller you go in terms of your population of focus.
And then Abby, for your model, you would need cases in order to do curve fitting. Is that right?
Deaths.
Deaths,
right. Yeah. So we don't believe in cases. And I would love to use cases, but you need testing to be uniform enough that you can interpret cases. Because cases in the Seattle area have changed dramatically as we have developed the capacity to do testing. And early on, people showing up in the emergency room with clear COVID symptoms, if they didn't need to be admitted to the hospital and they were under the age of 60, they were told, we don't have enough tests for you. You probably have it, so please go home and try to stay away from people. And that makes it very hard to interpret data on cases, but data on deaths, we believe, is going to be much more useful. To use it in small areas, we do need to have enough deaths in the area. And my colleagues believe that 50 is a sort of ballpark number. Once a state or municipality or even small country has reached the threshold of 50 deaths total, they feel like they can get a good fit out of their model routinely. I think I can do less. And I did a fit for Guam recently that's only had 5 deaths that I hope has been useful to people. But besides the number of deaths, the amount of COVID happening in that population, and Professor Enns was talking about this a bit, the boundaries are very important. And local health departments, public health in the United States often happens at the county level. So doing things for, say, counties might make sense with the way data is being reported. Doing things for metropolitan statistical areas, which the Census Bureau has created as aggregations of counties, would be a good way to go below the state level, and I've looked at that a little bit. But working on, say, the Navajo Nation or many reservations that are not constituted of counties is a data challenge. Just like race and ethnicity data have not been provided regularly, data on tribal areas is not currently being produced, at least I haven't seen it. And it's a bit of a lift because it's not compatible with counties. In Washington State, once a year we geocode all deaths. And so in a year, we'll be able to say something about what happened. But what we were saying, we need to make decisions now. We need data today. I don't know of a data stream that'll let us really dig in to see what's happening on specific tribal areas.
May I interject one final question, just because I've seen it come up a lot in the group's questions, and that's around herd immunity and or acquired immunity after infection. How do the models cope with our lack of understanding about what happens to folks after they've gotten this infection the first time or the only time?
I bet Professor Enns is going to have a long answer, so I'll give a quick one.
Okay.
Because the caveat, the projections I've been showing refer only to the first wave of the COVID outbreak. And there's a lot of uncertainty about what happens next, and we have sidestepped that by focusing on deaths and focusing only on the first wave, only in the presence of strong social distancing.
Right.
Go ahead, Eva.
And so in our model, we have herd immunity is kind of foundational in the SEIR model in the sense that once people enter that recovered compartment, then there's an assumption of immunity. It doesn't have to be an assumption of perfect immunity. It doesn't have to be an assumption of permanent immunity, meaning that people could return to the susceptible state. But currently, we are assuming, for at least the timeframes that we're modeling, which is kind of out 1 year, we're assuming immunity is lasting. If that isn't the case, then there is certainly going to be risk for multiple waves of this as people maybe have a temporary immunity and lose that immunity. And we see that in other kinds of pathogens that generate cyclical outbreak cycles.
Thank you so much.
Thanks. Heidi, do we have time for one more question?
Yeah, do you have one in mind?
Yeah, I do.
Okay.
So I want to tell everyone that we'll make sure to include some references to documentation online for those who had questions that can be answered through those. So stay tuned for the links. Let's have a few questions for Abby, since he's our guest here in Minnesota virtually. There were questions about your projections of the peak, and the height of the peak has been changing quite a bit the last few days. There were questions about both how do you communicate about it and what do people need to understand as they look at a model at a point in time and need to realize that with a curve fitting approach, with any fitting approach really, these estimates are bound to change.
Yeah, so first of all, everyone should know that we're going to keep updating these estimates. As additional data comes out, we're going to keep changing the estimates based on new evidence. And wouldn't it be nice if we had just got it right the first time and didn't need to change it? But as we learn more, you know, we're learning critical things that we didn't know. That's going to lead to updates. For some people, they are so busy, they can hear only one number about how many total deaths we have projected for wave 1 of this outbreak, for example. And they want to key in on that number as the thing that we have said. Now, if you have time for 2 numbers, let me give you a lower and upper bound to go with that single point estimate, because you might think, if I switch over to the United States view, I can tell you just what it says for how many deaths we're projecting in the United States by the end of wave 1 of this epidemic, 72,000. But if you have time for 2 numbers, please let me remind you, we believe it could be as low as 60,000, which is really where we're at now. It could be as high as 114,000. And of course, that is all assuming strong social distancing, which we know is now changing. So it may be irrelevant by the time you can check my work. And of course, that is assuming all of the things that I have also added, such as strong social distancing in the United States works as well as it has worked in other places.
Thank you. Thank you. Thank you to both of you, Eva and Abby. The ticker with the Q&A questions is just keeping to go up. So we could have done that for hours, but thank you so much for everyone's insight, for your hard work to serve the public's interest, and for being willing to present your findings and explain about the science that drives the work that you do.
Yes,
and Heidi, thank you to the university for setting this up.
Yeah. On behalf of our school, thank you to all 3 of you, and to our attendees for joining us. And we hope you have a good day. The recording will be available